Good afternoon, everybody. It's my pleasure today to moderate this presentation by Dr. Majed AlKharashi. Actually, the secretary, she sent me the title in the beginning as the cornea without any detail. Then I was thinking, what is going to talk about the cornea? This is a big title. Now, when I see the title of his lecture, now I can understand what he's going to talk about. Anyhow, Dr. Majed AlKharashi, I'm sure all of you know him, and Dr. Majed, just for those who attend our grand round, he finished his MBBS in 2003, and he's now assistant professor at College of Medicine, King Saud University. He did his residency from 2006 to 2001 in McGill University at Montreal, and he did fellowship in Wilmer and Eye Institute from 2001 to 2012, sorry. And also he worked as a staff there from 2012 to 2013. Luckily, he came back, and we have Dr. Majed AlKharashi now in the King Saud University. He did also a master's degree in medical education. I know Dr. Majed for many years, and he has an interest in education, and I'm sure this is well known from his residents and his fellows as well. Dr. Majed also had, some publications as well, and he participated in some chapters, and he had a lot of awards. I'm not going to mention it. Today, Dr. Majed, he will talk about evolution of the corneal transplant. I will leave the microphone to Dr. Majed. I'm sure it will be an interesting lecture. Dr. Majed.
Thank you so much, Dr. Asiri. Choosing the title, the cornea, it's part of the suspense. So people will be wondering what I will be talking about. But I can assure you that I will not be hammering your head with a lot of scientific information. Rather, I will be just telling you the story of corneal transplant and how corneal transplant get evoluted over the years. The word graft derived from the Greek word graphein, which means writing and implement. And they used it to describe their monsters like this guy here, who has a body of a lion, a tail of a dragon, and extra head of a goat. And it was used in the 15th century by agricultural people, where they will take a branch fruit tree, and they will graft it to another tab of a fruit tree. However, it was not used in medicine till the late 19th century. In the 18th century, corneal scar because of trachoma was really a big problem in the French and British soldiers who were campaigning in Egypt during the Napoleonic War. And because of trachoma, ophthalmology became the first surgical subspecialty. And this gave the stimulus for the foundation of Moorfield Eye Hospital back in 1817. As anything new, it usually starts with the thoughts and idea. And the first one who thought of replacing a cornea was a Frenchman by the name of Coenzi, who thought of replacing an opaque cornea with a transparent material. The first one who thought of doing the experiment was Hemley and his student Risinger, where they took a cornea from one animal and they placed it in another animal. At that time, there was a debate of doing a Xeno transplant, where you will take the graft from an animal, or doing an allograft, where you will take the graft you will take the graft and you will do the transplant within the same species. In our case, of course, human. The first one who did a Xeno transplant was Richard Cassim in New York, where he replaced an opaque cornea with a 6-month-old pig cornea. However, this failed within 10 days. And Samuel Bigger did an allograft, but in animal, not in human. Von Hebel had many contributions in ophthalmology, one of which is the corneal trephine, which will allow us to cut the cornea in a circular fashion. Von Hebel was in favor of doing Xeno transplant, but not penetrating, rather lamellar keratoplasty, as he believed that the inner layer of the cornea has an important role in keeping the cornea clear. The first one who did successful penetrating keratoplasty was Eduard Zirm, who's an Austrian ophthalmic surgeon practicing in the Czech Republic in a city near Prague. This is when he encountered a patient by the name of Alois Gloger. Gloger had a chemical burn injury in both eyes 18 months prior to his presentation to Zirm. And in the same day, Zirm had the kid with very bad penetrating trauma that needed inoculation. And after taking the kid's father permission, Zirm cut the kid's cornea into 2 5mm corneal graft, and he did a bilateral penetrating keratoplasty for Gloger in the same day. The right eye failed immediately. However, the left eye was clear, and the patient was able to go back to his daily activity and to do his work. Since that time, there were a lot of development in the ophthalmic field, like having small, tiny sutures that will allow us to suture the graft in place, having surgical microscope, anesthesia. Lister also described the principle of antiseptic practice in doing surgery. And Vladimir Filatov in Russia came up with the idea of taking the cornea from cadaver eyes rather than living donors. And Richard Patton established the first eye bank in New York in 1944. Also, Edward Momini recognized that one of the reasons for corneal graft or corneal transplant failure is graft rejection. Since that time, people start to master penetrating keratoplasty. However, the idea of lamellar keratoplasty came up again. And maybe this because of the advancement in the diagnostic as well as the surgical tools. And as you all know, lamellar keratoplasty carries a lot of advantages over penetrating keratoplasty. For me, at least, posterior lamellar keratoplasty is more interesting. The first one who thought of doing posterior lamellar keratoplasty was Tylett in Baltimore, Maryland, where he dissected the posterior lamella surgically and replaced it with another dissected posterior lamella, where he had to suture the lamella in place. However, the technique did not take off as the surgery was very complex and there were a lot of complications. Dr. Millis, on the other hand, I think he had a major role in the development of endothelial keratoplasty. First, he described using the air to tamponade the graft against the patient's cornea, then doing dysmatorexis rather than surgically dissecting the posterior lamella, and finally doing DMAC, where you will transplant only the Descemet membrane with the endothelial cells. This patient had a DSEC a few weeks ago for pseudophakic bullous keratopathy. The patient and myself were extremely happy, and we thought that really we can't beat this outcome till we start doing DMAC. There's a patient who had a DMAC a few days ago for pseudophakic bullous keratopathy, and this is the same patient at 1 month. And really, you can't tell that this patient had any corneal transplant. If you look at the literature, there are many articles talking about the advantages of DMAC. However, if you look at this Cochrane review, where they depend mainly in type A articles, they concluded that there is low certainty evidence that DMAC provides some advantage in terms of best corrected vision at the cost of more complications, more graft dislocations, more needle-free bubbling. However, we know from our experience that really DMAC has a lot of advantages, and it's a procedure that is worth doing, but you have to choose your patient wisely. Now I'm going to present 3 random slides. This is the first one. You know, after doing DMAC for some times, Millis noticed that even when the graft is slightly dislocated and there is area of peristroma, the cornea will eventually clear up. So he thought of doing a hemi-DMAC, where he would cut a larger graft into 2 half moon, and he will place this half moon in the eye. And the results were comparable with the conventional DMAC, although sometimes the cornea took some longer time to clear up. And last year, he published his quarter DMAC, where he took only 1/4 of the graft, and the results were comparable with regular DMAC. Again, however, it took slightly longer time for the cornea to clear up. Okamura and his group in Japan tried to treat endothelial dysfunction medically. And they have few patients where they treated, for example, Fuchs endothelial dystrophy with Ripasidil, which is a rock kinase inhibitor, after freezing the center of 2 mm. And also they tried this in patients who lost the Descemet membrane during cataract surgery, and patient who had endothelial burn from argon laser during a PI. The third slide is also, I found it very interesting. This group in Emory University did a DSEC for a patient with PPMD confirmed with cytokeratin staining for the specimen, the histopathology specimen that they sent from the patient's own cornea. And if you look at the cornea, you will see that where the graft is detached, the cornea is clear. However, where the cornea is attached, the cornea is edematous. And after many attempts to attach this graft, they eventually decided to remove this graft, and the cornea cleared up nicely afterward. Another group in UK noticed the same thing with Fuchs endothelial dystrophy. And the explanation that the patient's own endothelium at the periphery will migrate, maybe proliferate, and cover up the area, the stripped area centrally. And from this, the idea came of doing only stripping of the diseased Descemet membrane with the endothelium and removing the guttate. As you can imagine, this has a lot of advantages, one of which you reduce the rate of surgical complication. There is no rejection because there is no graft. 1/3 of corneal transplant performed in the United States were because of Fuchs endothelial dystrophy. So imagine how much corneal tissue you will save by doing this procedure, and less cost. The cumulative cost for endothelial keratoplasty in the United States is around $120,000 US, compared, for example, to $400 US for Ripasidil eye drops. This is one of my patients. This patient had ECC by another surgeon in effort to save the endothelium from the ultrasound energy for the phacoemulsification. Then after 3 years, this patient had the ECC around 2016 or so. Then after 3 years, the patient presented to me with corneal edema. And what's really striking more than the edema, when you look at the OCT picture, I don't have a pointer with me, but if you look in the OCT, you will see that there is high signals coming from the Descemet membrane, and this represents the thickened Descemet membrane with the guttata. It's well known that corneal guttate has some visual problem. And after long discussion with the patient, we decided to do a DeWick procedure, where we'll just strip the Descemet membrane without placing a corneal graft. This is the surgical video, just to show you the procedure itself first. The patient has slightly upward drawn pupil, but this is more because of the pyrocarbon drops that we use prior to the surgery. So it's just to strip the Descemet membrane without touching the stroma in one area, then do a dysmatorexus rather than scoring the whole membrane with the reverse Sensky. The patient did well, and her vision improved after the procedure, and you can tell by looking at the anterior segment OCT, all this high reflectivity disappeared after doing DWAC. And the retina people were able even to treat her diabetic retinopathy after this procedure. Now I'm going to review the literature in DWIC. Borkar classified the response of DWIC, which is dysmatorexus without endothelial keratoplasty, or DSO, which is Descemet stripping only. And they classified it to fast responder, and slow responder. Fast responder, when the cornea will clear up within 1 month from the procedure. Responder, when the cornea will clear up within 3 months, and slow responder after 3 months. And they found that maybe thicker cornea will not respond as a thinner cornea. However, the sample size was very small. However, they noticed that even if, in the patient who did not clear, in the cornea that did not clear, when they did DMAC afterward, there was no implication of the previous DWIC. Wang did a comparison study between DMAC and DWIC, and he found that the outcome or the results were comparable, except for time to achieve 20/40. This was statistically significant in the DMAC group, where they achieved that 20/40 vision around 2.2 weeks compared to 7.1 weeks. On the other hand, the adverse event or the complications were statistically significant in the DMAC group. But again, these adverse event was like some dislocation. And they recommended that we do DMAC for monocular patient or patient with type A personality, patient that can't wait to clear up. Then do you hear me, Dr. Abdullah?
It sometimes cuts. Yeah, it sometimes cuts. You know, I think.
Hello.
Maybe you have some. Do you have any internet problem? Sometimes the sound cuts, Majed.
All the time, or
no, just the last 2 minutes only.
Okay, so please let me know if you have any problem, so I can change the Wi-Fi. So Max Tsai in North Shore University in Chicago compared DSO, Descemet stripping only, and DSO with Repasodil, which is a rock kinase inhibitor. And they found that the Repasodil group had a faster recovery, more endothelial cell density centrally, and less drop in the peripheral endothelial cells. So again, the DSO group alone without Repasodil, the outcome were comparable, except for the Repasodil group had faster recovery, more endothelial cell count centrally, and less drop of the peripheral endothelial cell count. This maybe indicate that Repasodil might help the corneal endothelium to proliferate not only to migrate. And now let's talk about RUC kinase inhibitors. The cell cycle for the human corneal endothelial arrest in the G1 phase. And this is because of the contact inhibition. So when one endothelial cell touches another endothelial cell, the growth will stop. This is because of the upregulated B27KIP1 cyclin protein that will prevent the cell from proliferation when one cell touches another cell. The RUC kinase inhibitor play with this cyclin protein signaling, and this will allow the cell to migrate and maybe proliferate. Because of this finding, we did the pilot study where we used the Dystrophy, the RUC kinase inhibitor, during phacoemulsification in patients with PNS grade 3 nuclear sclerosis, and we found that there is less endothelial loss compared to the reported in the what is reported in the literature. And currently we are doing an RCT with a larger sample size. Davis looked at the factors that might indicate which cornea will clear after DUIC, and they looked at all the variables, and they found that corneal thickness, the age of the patient, and the endothelial cell count did not really play a major role in the success rate of DUIC. However, they found that the surgical procedure itself has a major role in the success of DUIC. They found that stripping 4 millimeter rather than 6.5 or 8 millimeter has better success rate. And they found that stripping rather than scoring the endothelium has better success rate. And the problem...
سامعني يا دكتورة؟
Hello? And this is because scoring is when you use the reverse Sinski to strip the endothelium. Stripping when you use the forceps to peel off the Descemet membrane with the endothelium in a rhexis fashion. And the problem with the scoring that sometimes we injure the posterior stroma, and this will form like a fibrosis or a nodule that will prevent the endothelial cells from migrating centrally. I have a limited experience in DUIC, but even talking with the corneal surgeon who did DUIC, it's really not my first choice for treating endothelial disease. So I'm gonna just mention a few things that I do in my practice. First, if you want to do a DMAC, you have to select your patients wisely. You have to choose your battle. Our job is to help our patient to see better with less risk of complications or problem. Like if you have a patient with bad corneal astigmatism, corneal scar from trachoma, retinal disease, you will not do him a favor if you do a DMAC. This patient will not reach 20/20 anyway. You will just struggle during the procedure trying to find your tissue. I remember one time I was telling my fellow, I will buy you a dinner if you can't find the S stamp in the graft. So again, it's a good procedure, but you need to be smart though. You need to be smart. You need to choose your battle. And again, it's not about ego here. You want to help your patient with less problem. Like if you will spend 40 minutes, for example, trying to unfold or trying to see at least where is your graft, with this manipulation, you will lose some of the endothelial cells. So maybe DMAC is not a smart option in suboptimal corneas. I use pre-strip, pre-loaded, pre-stained, pre-stamped tissue with a Gauger tube, and having this pre-stripped tissue that will stay in the tube for a few days till it reach to us. Sometimes maybe unfolding will not be easy. But anyway, my point here that sometimes when you inject the graft and the stain start to fade away, you can't really see your graft very well. You can stain your tissue inside the anterior chamber. Just fill the eye with Vision Blue, wait for 1 minute, then wash out the Vision Blue gently with BSS. The second thing, using glycerin drop. This is really a game changer. When you apply the glycerin drops prior to the surgery, the cornea will dehydrate a bit, and this might allow you to see better and to do your surgical steps. This is no brainer. If you have subepithelial fibrosis, you can peel off or doing lamellar dissection or superficial keratectomy to remove this fibrosis, and you will be surprised. You will be surprised how much visibility you will have. I'm trying to show the video for the superficial keratectomy for this patient, but I don't think it's running down there. But anyway, like this is the down below to the left. This is the same patient in the table after removing the superficial scar. I was fortunate enough to try many insertion technique for DSEC. I tried the TAN glide, the Busen glide, the forceps, the endoserter, and believe me, at least in my hand, the sheet glide or the lens glide is really peace of mind. First, it will hold the lens and the iris back. It will prevent iris prolapse. And when you inserted, the tissue is already unfolded, is waiting for you to inject your air. And you can play with the wound size according to your graft size. My third or fourth tip is doing during temporary keratoprosthesis. Although this video will not show my tip, but at least this is the video that I found for temporary keratoprosthesis in my library. Usually we do temporary keratoprosthesis for complicated cases. A phakia patient with unichamber, no much of scalar rigidity. You can put a Flaringa ring, but you will struggle with the speculum, with your sutures, with your trocars. And what I found really again game changer, if I may call this, is pre-placing your vicral suture. So pre-place your 7/0 vicral suture before trepanation. So what I would do, I will pass my 7/0 vicral suture at 6 o'clock, saddling the limbus, partial thickness of course, and thread it in the hole in the Landorf device, and they will do the same thing at 12 o'clock and set the device aside, then do your trepanation. After you do your trepanation, bring the device and tuck it in the hole and tie your sutures. It will take you maybe 30 seconds till you tie your sutures, and the patient will have open sky for less than a minute. And if you place the first two, the surgery basically is over. Like placing the other is not that difficult because you have closed system now. This is a video of one of my DMAC. I just want to show you the step that I really admire so much, which is placing the glycerin. So I will, after removing the epithelium, I will place the alcohol well, then I will place the glycerin. I will keep it for 1 minute, then I will wash it. You need to spend some time because it's thick. It will not be easily removed by the Wexel, and you have to irrigate it. Then this is my my goiter. So look at the cornea. It's reasonably clear. It's not that bad, And when you're inserting the graft, if you see that there is significant shallowing of the anterior chamber or significant posterior pressure, I prefer to pass the pupil margin with my tube, just to prevent the chance of having the graft to going to the sulcus. And then of course, as you yeah, and all deflate your eye before coming out, and that's it. So this is now. I'm going to go to the interesting part. All the previous half an hour or so was a bit, I know, boring, but this one I think is more interesting. So this is a 68 years old gentleman who came to my clinic because of dense cataract and bad corneal edema. The patient is very sick. He had kidney transplant, very obese, very depressed. He can't sit in the slit lamp. He went to many ophthalmic or eye clinic, and they did not do the surgery because of his medical condition. And again, here you have to be smart. You don't want to rebubble this patient or have complication. So better to do a DSEC net edema. Anyway, and I remember I was talking to him talking to him, walking him through the surgery and what we will do, how would you approach his problem, etc. And in the middle of the discussion, he stopped me. Then he said, "Doctor, why not just to remove my eye?" Huh? So he was really depressed. Anyway, so we did a triple procedure. We did a phaco with a DSEC. The surgery went beautiful, like amazing. Yeah. Next day, the graft was attached 100%. The cornea was clear. The patient was happy. I was happy. Huh? So everything was perfect. Then I received a call in the post-op day 8. I remember this like yesterday. I was, Wallah I was walking in the beach in the eastern region when I received the call saying that the corneal scleral rim positive for Candida albicans. And not only positive, he had heavy growth of Candida albicans in the corneal scleral rim. And now I will ask my cornea colleague, our cornea expert, to jump in and to answer these two questions. Number one, how this will, first, what do you do? Do you culture the corneal scleral rim or not? Like, what do you do in your institution? Number two, how this piece of information will change your management. So أبو أحمد أنا في ناس وعدوني إنهم they will participate.
Okay. I think the standard, I remember in Kekish, any rim, culture rim, any rim, they will culture it. And usually, mainly if there is a positive fungal candida or any other, they will inform the surgeon. And I remember, the standard that if we have a positive culture, we start the patient on antifungal as a prophylactic. So at least for like 4 to 6 weeks. And then this is for the BKB, definitely. But this is the situation here is a different. This is a DASIC, and the tissue is inside with the germs. So whether to wait, give antifungal, wash it with an antifungal, or you just be on the very safe side and you just go ahead and change it. This is another way, because I think if you keep it, if it is candida really and it's deep, it's very difficult to treat. This is my opinion. And if there is, if someone would like to give his opinion, it's fine.
Well,
okay.
I can't see the names, but anyway,
I see maybe around 160 participants, but probably okay. Okay. So
well, I was really excited to hear from
others. Okay.
like this 160 attendees. They are here for you guys to give your like your comments, they are not here for me. So anyway, okay. If someone raised his hand, stop me, Dr. Abdullah, and I will stop. I will proceed.
Yeah, sure.
So we having this piece of information, and I agree with you, Dr. Abdullah, and you will see what I did with my patient. But having this piece of information got me thinking, and we reviewed the literature, and we found this nice article that looked at the value of culturing the corneal scleral rim, and they looked at all these studies, and they had around almost 8,000 corneas. And around 12% of these corneas had positive rim culture. However, only 12 patients had keratitis or endophthalmitis. So if we break down this number, 12 patients had infection, 9 of them were fungal infection and 3 bacterial infection. 6 of the fungal infection were keratitis, 3 were endophthalmitis, and two of the bacterial infection were keratitis, and 1 endophthalmitis. Maybe it's worth to mention here that, in the corneal transport media, we have gentamicin and streptomycin antibiotics within the media itself. And routinely, we prescribe topical antibiotics to our patients. So if we look at the corneal infection, you will see that all of them had negative rim culture, and the infection started maybe 2 or 3 months after the procedure. So maybe, the graft itself has nothing to do with the infection. This is just maybe the luck of the patient that they developed the infection. But what is striking, if you look at the fungal cases, all of these patients, the 9 patients, had a positive culture rim with the same species like what the patient had. Okay, and if you look at the positive predictive value, so the positive predictive value of rim culture for bacteria and fungus was 1.5%, which means that if you have a positive rim culture, regardless if it is bacteria or fungus, you have 1.5 risk that the patient might develop either bacteria or fungal infection. But if you look at the positive predictive value for fungus only, it's 10%. It's 10%. So if you have a positive rim culture of fungus, this patient at risk to develop either keratitis or, God forbid, endophthalmitis, 10%, which is a high. I think it's a high percentage. So, like, if you have a positive rim culture of a fungus, this patient who came to you with the only hope that his vision will be better, he has 10% risk to have an infection, not only keratitis, maybe even endophthalmitis. So it's very, very striking number for me. And not only this, so if you, for example, in my institution, they take a swab from the culture rim and they will place it in a broth. And if there is growth, then they will break the specimen into the cultural plates. So a single negative test for bacteria and fungus will cost around $14. And for fungus only will cost around $4.5. If you have a positive result, the cost will increase, of course, because you have to use more plates. So for bacterial and fungal, it will cost around $46 per cornea. And for fungal only, it will cost around $27. And if you want to do the culture for all the corneas that was reported in this study, which is around 8,000, the cost will be almost $142,000, and for fungal only is around $40,000. But if you look at the predicted value, though, it's only 1.5% for bacteria and fungal together, and 10% for fungus only. So, I think, in my opinion, in my humble opinion, I think doing bacterial and fungal screening is not worth it. It's costly, and more important, it will not add much. But having a fungal culture is very important because the risk of infection is 10%. Not only this also got me thinking and wondering again. Maybe it's better not only to have antibiotics in the optisol in the corneal transport media, but maybe having an antifungal agent is a good idea and smart thing to do.
Majed, yes. Okay, it was disconnected. Okay, now I can hear you. So it was disconnected for so maybe the internet and you're unstable.
Maybe. So I will repeat it. I was saying that in my institution, we do swabbing for the corneal rim, and we place the swab in the broth. And when there is growth, then we will break down this bacteria into culture plates and to see what is the organism. So the negative test for bacterial and fungus costs around $14. Dr. Abdullah, do you hear me? Dr. Abdullah?
Yes, I can hear you.
Okay.
Yes.
And for the fungal screening only, the negative test costs around 4.5. And the positive test for bacteria and fungal costs around 46. Anyway, I was talking about the cost of the culturing the rim. If you want to culture the whole 8,000 corneas, the one that reported in the study, it will cost around $142,000 compared to around $40,000. And the predicted value for the bacteria and fungal is only 1.5% compared to 10% for fungal. So my humble opinion, I don't think it's worth to do bacterial and fungal screening. And more important than the cost, it will not add anything for you. Even if you have positive culture, it will not change you. It will not help you. I think you're disconnected again, Dr. Abdullah, correct?
I think
the
sound, we can hear it, but we can hear you, but sometimes the video is not stable. But yeah, go ahead, Majed.
My internet connection. Hopefully, it will be better.
Okay.
So, but my point is clear regarding the cost and worth doing the culture or not.
Yes, it's clear. Sure.
Okay. I'm about to finish anyway. So for my patient, don't forget that the patient is sick and has had kidney transplant. So you need to be very careful, because I remember a story of a patient who died, unfortunately, because of voriconazole. The patient had acute hepatitis, and the patient unfortunately passed away. So you need to be very careful, especially with these sick patients. So we discussed this with his nephrologist, with the internist, with the clinical pharmacist, with everyone. And we elected to give the patient voriconazole 200 milligram BID for 10 days, because, as you know, the patient had a DSEC, and if God forbid he developed an infection, it would be very difficult to treat it. The only option is to do a therapeutic PK, because there is a potential space, sequestered potential space that you can't reach with the topical medication or any sort of administration of medication. So you are talking about doing therapeutic keratoplasty, or حتى يمكن the patient might have an endophthalmitis. Anyway, my patient is doing fine, and he is happy, and that's it. Thank you so much. So we took around.
Yeah, I think, yeah. Thank you, Dr. Majed. Really, it's very nice, and very nice cases that you presented. Maybe because since we are in the last case, maybe I can just ask you a few questions. You know, the first question, did you think of giving like an intracameral washout with antifungal rather than giving, you know, systemic, you know, voriconazole, or you do the both combination of intracameral antifungal with the systemic antifungal medication?
Well, you can try as much as you can. There is no golden there is no gold standard here. But you know, injecting a intracameral voriconazole, you might risk losing some of the endothelial cells. You might damage your graft. And if you look at the 9 patients, they tried all sorts of things. So even I doubt that my voriconazole did anything to the patient. It's just, alhamdulillah, God will help me here. Like, and if you look at all the 9 patients who had positive, they tried everything. They removed the graft. They irrigated the eye with voriconazole. They give subcoins. They give intracameral, intracorneal. All failed. But to answer your question, you know, we did a close observation, and I did not want to do anything intracameral, as I did not want to damage my endothelial cells.
There is one question from Dr. Muhammad Al-Mutlaq. He's asking, why not topical amphotericin as a prophylaxis?
Yeah, you can, but don't forget that, you know, all antifungal agents will not penetrate the cornea easily. And the problem is in the Descemet graft, which is way away from the ocular surface. But this again, maybe it's worth to highlight it here again. The culture of the culturing the rim for fungus is very important, because you can predict the organism. But for bacteria, we use antibiotics in the Optisol, and we give topical prophylactic post-op. We don't give topical prophylactic antifungal, and we don't use antifungal agent in the Optisol. But yes, like I doubt if we give topical medication, it will penetrate to the Descemet graft.
Okay. Maybe we go back to the DUIC. I think I have a question here. DUIC case after ECC, how did you assess the peripheral corneal endothelial cells, as one of the criteria should be 1,000 endothelial cell count? This is one question. I don't know who sent the question, but he's asking about assessing the peripheral endothelial cells. In your case, that who had ECCE with low endothelial cell count to start with?
It's an excellent question, because if you look at the study where they compared DSO with Ripasidor and DSO alone, they looked at the corneal endothelial cell count at the periphery. In my case, we did not do it. But you have to decenter your confocal microscope to get the image at the periphery. And again, like this might open another door of variation. And are we really measuring the real endothelial cell count or not?
Because I think DUIC probably is maybe good for Fuchs endothelial dystrophy, because they have the guttata centrally, and you know the cells can migrate nicely. But as you said in the beginning, I think selecting the right patients is very important, and understanding, when you decide for a patient a procedure, sometimes these procedures you might repeat it, or you might do something else, you might do, you might add something to this procedure. So if this patient will understand all this scenario, you can, be, motivated to do, for example, to start with the DUIC. If it did not work, you can go to a DEMIC or probably ultra thin DASIC. So selecting the right patient, I think, is important. Also the pathology, sometimes I see some patients with the long-standing chronic edema. I think they may not clear with the DASIC or even with the DIMIC. So those patients, you might just go for total corneal transplant. Any comment, Majed, on this?
Well, yeah, I agree with you 100%. And the only indication for DUIC is for Fuchs endothelial dystrophy. It's not for pseudophilic bullous keratopathy. But having done DUIC, again, I have limited experience. It will not be my first choice as a surgical procedure for patients with Fuchs dystrophy nowadays.
We will open for any questions if someone would like to ask, or he can send questions. This is a question. Did you notice difference in survival between pre-cut tissue and tissue you prepare for DASIC?
Well, I do only pre-cut tissue. In my institution, we do only pre-cut tissue. And our success rate is good and reasonable.
Okay.
But there was, I remember someone talking about, cutting your own tissue maybe will have better attachment rate compared to pre-cut tissue, because the cornea was freshly cut.
I used, I used to the microkeratome, then I passed to I used the the femto laser to do the cut. And nowadays, probably for the last, I would say 3 years, I'm using the pre-cut. It's very nice. It also shorten your time in the because sometimes you'll struggle with the cutting the tissue. And if you don't have an eye bank, really, it's sometimes difficult if there is any problem when you cut your tissue. But having a pre-cut, it's and even you can request what type of basic flap you need, whether thin or thick or whatever you need. I think we have Rawan Shabib. She has a question. She can go ahead. Dr. Rawan.
Assalamu alaikum. Yes, assalamu alaikum. I'm Rawan Shabib, anterior segment consultant at KKISH. Thank you, Dr. Majed, for a very informative presentation. And I have a comment regarding the positive fungal culture of the donor rim. As you said, it is having a positive culture of the donor rim is more predictable for post-op keratitis or endophthalmitis than bacterial, which is approved in the literature. And we had a study here at KKISH. We studied over 10 years the incidence of fungal culture of the donor rim, and we found that the rate is 1.5% over 10 years, and none of them had keratitis or endophthalmitis post-operatively. So I agree with you. It is risky to have a patient with a positive culture of the donor rim, and whether to start prophylaxis or not, it's still controversial based on the literature, and there's no consensus regarding whether to start antifungal or not. But in our hospital, we are doing a fungal culture of the donor rim for bacterial and fungal. And we have also sensitivity. We do sensitivity. If there is a fungal results, we do sensitivity reports regarding for the candida, especially because it is the most common organism. And Dr. Ozori kindly shared the link of the paper in the comments. So yeah, it was done during my fellowship, and our routine now for most of us is to start on topical antifungal if we have a positive culture of the donor rim.
Thank you so much, Dr. Sharif. I just want to ask her again, maybe I missed this. She had 1.5 percentage of the
positive fungal culture.
Yeah. Out of 9,000, yes. Out of 9,000 graft, we have only 1.5% positive culture of the donor rim.
For fungal or fungal and bacterial?
No, fungal only.
No, fungal. I think bacterial should be more, isn't it?
Yeah. Yes, yeah.
Well, in the study that I just showed you, they had a similar number. No, actually, no, they had 12%. 12% positive rim, and most of the rim were bacteria?
Yeah, so bacterial is more common, and it could be more of contamination of the ocular surface than fungal. It is rare, but the problem is when the patient has positive, fungal keratitis or endophthalmitis, usually end up bad. Fortunately, it's very rare. So we recommended to start on to at least topical antifungal, and to do close observation of the patient. If he developed like keratitis post-operatively, one of the treatments that was described in the literature is to remove the lenticule and to wash with intracameral if there is infection. If there is no infection, better to observe the patient, close observation, and because some of them develop the infection late, like 6 months post-operatively. So usually they are at high risk, and it's really a difficult issue whether to continue on steroids or not, and what's the dose of the steroid. So it is critical, and we had a few cases in Kekesh in the last 2 years. And one of them, I followed him. He had positive culture of the candida. It was a triple procedure, and I followed him for 1.5 years, and I started him only on a topical voriconazole and amphotericin, and he ended up with no infection post-operatively.
Interestingly, I think I remember we reported one case of delayed fungal infection from the donor rim.
Yeah, it was post-PKB.
Yes, exactly. And it was, I think, months after that. And when we go back to the culture rim, it was positive for, I think, candida. So yes, it's, I think then I think I remember when I was there, we used to, as you said, we give prophylactic antifungal when it is positive for culture. And I used to remember Sayed, who was the senior bank technician, he used to call the surgeon that your donor tissue rim is positive for this type of fungal. So we used to give prophylactic, topical antifungal medicine. But I remember we used to give it like for 4 to 6 weeks. Then after that, we stopped it.
So now they are sending emails if we have a positive culture, especially for fungal, to the surgeon.
That's good. Yeah.
Thank you.
So, sure. I don't know if we have another further questions, or we can, anything you would like to add, Dr. Majed, before we conclude?
I just want to thank really Dr. I just want really to thank Dr. Rawan for her comments. And yeah, if you have infection in the interface, most of the time it's kind of game over. You will need to do it. Okay. So,
I think at this, now we are 3 o'clock. I'd like to thank Dr. Majed for his nice, informative grand round. Also, I'd like to thank anybody who commented on this grand round. Thank you for all.
في ناس وعدوا انهم they will participate, عليهم حق ترى.
خلاص ان شاء الله the second grand round ان شاء الله.
لا ونروح للمدينه.
اوكي ان شاء الله.
نروح للمدينه
ان شاء الله. خلاص عرفناهم اجل. Thank you, Dr. Majed, again, and thank you for all people who attended this grand round, and we'll see you inshallah again in next week for another grand round. Thank you all, and have a nice day. Thank you, Majed.